Hello and welcome to the EMS Handoff podcast. This is David, and along with my co-host Eric McCullough and the videoless Bradley Dean. We are your source for all things EMS, and we're going to get started with a group of guests this evening. Bradley and Eric, you notice how I took distinguished out of there. That's completely out of my script, and that's going to be absolutely proven this evening. But every week that we do that, we end up with a great conversation. But before we do, we're going to kick it over to Middle Tennessee and see how Eric is doing. He's wasn't with us last week, left Bradley and myself all but unsupervised.
Yeah, unsupervised. Did not, probably copious edits in there, I'm sure, without me.
Why?
No, I can't imagine why. I can't imagine.
So how's things been going?
It's busy. You know, I work that. We've been really busy with one of my jobs is I work at a pediatric clinic. So those pediatricians there and us, we're getting our butts handed to us. And the weather's good though. Got to say the weather's good. Our garden's finally taken off. So we get to have real salsas at the house versus just trying to get stuff from the grocery store. So that's kind of nice.
Well, can't beat homegrown stuff. They're talking about 8 inches short on rain for the year, and I don't really understand that because it seems like it's raining every other day right now. But hey, we'll take it. You know, that just means that next weekend I actually have to mow the grass. But Bradley Dean without video. So how's North Carolina treating you?
Well, y'all are talking about the in a monsoon. So the weather here actually has been pretty good today until now. We've got this rain that's going to move in for the next couple of days with the tropical storm and all the lightning and stuff.
We're just going to love. He's out there in a monsoon and still taking on this EMS Handoff podcast. I am going to be a shameless plug. Normally we are in our EMS Handoff gear. I am sporting the dad shirt for the first time. We dropped our daughter off at university for the first time, and yes, you know, it's I don't know that it's set in just yet Friday, but let me just tell you this school, and we're a little bit spoiled because that's where my wife also is a faculty member. Like, they actually bring all the sports teams out and they set up at each of the dorms, and they actually unload the vehicle and take it to the room. So you don't even have to get out. And I will tell you, they are like vultures. So they pulled up to the room. I wasn't even hit the button to open up the tailgate on the Tahoe. They were already opening and grabbing stuff and tell us where to go. And they were gone. And I've never seen a Tahoe completely emptied in about 3.5 minutes. But that's all it took.
Drop off.
Right. It was. And, you know, the thing was our daughter got out and my wife and I were like, oh, right, we can go now. Right. And so we got her dropped off for her first semester. Looking forward to see how she does. She's pursuing biochem with a pre-med major. So what fitting day we have the docs. But before we get into them, let's thank our podcast sponsor, the Journal of Emergency Medical Services. They've been a great partner to the EMS Handoff podcast. They've been an industry leader for many years. So make sure to go by and visit JEMS at their website, jems.com. You can also catch all of our previous episodes on their website, as well as check out their fellow podcast hosts that we have there. Also, don't forget to go by and check out the EMS Handoff line of merchandise at the Pursuit Company. They've been a great partner to us as well, providing the Keep Back line, which was a real big hit at our most recent conference. Go to thepursuitco.com and find us under the affiliates page. Now, our guest for this week, we have the infamous, illustrious, the docs from Tennessee. So we have Dr. Joe Holley, the state EMS medical director for the state of Tennessee, and also Dr. Todd Heffern, who is the chapter president of the Tennessee chapter of National Association of EMS Physicians, and as well as an EMS physician at a local hospital here. Dr. Holley, you do it just about all. You've got disaster response that you do, coming back recently from the collapse in Miami, helping lead Tennessee Task Force 1, your medical education, your practice. Is there anything you don't do, sir?
Oh, there's plenty I don't do. But I'm glad to be here tonight, guys.
And Dr. Heffern, you're out there, multiple EMS services, medical directors. You have hit the technology stride, developing EMS applications to bring your protocols a little bit more live to some people. What else have we missed for you there?
That's enough. My head hurts just thinking about those few things.
All right, so we're going to talk about you guys tonight, to your face, not behind you, which is a great thing. But we're taking a look at the American College of Emergency Physicians position paper on EMS medical directors. So, really, I'm going to start off with Dr. Heffern first, and looking at your role at a local level. What is the role of an EMS medical director?
Well, I mean, ultimately, it's having a structure and organization to essentially provide the care for that a single patient when the need arises. Now that you start adding layers to the onion on top of that, but I mean, at the end of the day, we're all here for that patient, and so there's your toolbox, so to speak, with your clinical guidelines. There's the training aspect of that. There's your quality, assessment aspect of that. And then obviously, coalescing that within a whole EMS system to be prepared for, for us in Knox County, having about 500,000 people to be prepared to have, many potential single patient encounters at the same time.
Let's take that then on a different level, Dr. Holley, and take a look at the state level. So you're charged ultimately overall with the entire state of Tennessee. As Dr. Heffern said, one area of his is about 500,000 in population. You're sitting at about 6.5 million. So what does the role of the state EMS medical director have?
Well, that job is to help guide the division of EMS, the Office of EMS in the State Health Department, related to regulations, rules, the need for changes or additions or development of new laws as our practice evolves. The state also has responsibilities of oversight of ambulance services, setting standards for minimum requirements, everything from cleanliness to the right equipment on there, that sort of stuff. As well as oversight of all licensed personnel in the state to ensure that complaints are handled appropriately, providers that are in trouble or not performing to standards are either remediated or removed from service altogether. And then liaison work with the other branches of state government, particularly in the last 18 months or so with the pandemic. So lots of time with TEMA and State Department of Health and Governor's Office and National Guard and on and on and on, that sort of stuff.
So a wide range, but ultimately under your all's licenses is where we all kind of practice. So before we really kind of get into it, so ASEP put together this position paper. And it has 2 pages of bullet points of areas that the EMS medical director should be participating in. So before we get there, since that's a relatively new release, what is the common misconceptions of what the EMS medical director is? And that may be an odd way of asking that question, but what has been the history of the thoughts of the medical director?
Well, I think it's a question of the prior expectations, your old school approach behind, what was completely behind the scenes and hands off versus now, especially with really the explosion of EMS as a subspecialty of emergency medicine to a lot more hands-on. A lot more, you'll hear it called the active medical director rather than, a passive one.
So let's talk about that. So you come in, Dr. Heffern, to a new service. We're just going to call it XYZ ambulance service. Where do you start?
I think it's relationships. And that's starting with the field crews, developing a comfort level with them, and a bidirectional, respect. Honestly, I mean, you've got to earn their respect and their trust, and likewise. And I mean, obviously, you're building then internally within an organization and trying to reach out to, other first response agencies, governmental agencies, as Dr. Holley had mentioned. I mean, it's the same sort of relationships you're trying to build on a smaller scale for an individual agency.
And say, Dr. Holley, I know you've been sitting in your position for a little while, and you actually came in after a good individual that had been sitting here for many years. How do you take on that role at the state level, and where do you look to make your biggest impact earliest?
Well, I think for me, it was, following in the footsteps of others. And it takes a little time to learn the players at the state level and kind of figure out that role. I think it's really Todd summed it up beautifully. My real approach is sort of moving EMS medical direction from a very passive activity to a very active one. For example, I look back on services in the past, and I would have medics and, field providers who would say, "Hey, doc, we'd really like to talk to you about adding drug XYZ." And while I absolutely highly encourage that, the idea that the physician wouldn't be already thinking about that is concerning. And I've seen many EMS services where the doc offers nothing and is completely passive and simply waits for someone at the EMS service to request a new procedure, a new drug, or whatever. And that's the wrong way. I mean, if the physician is up to speed on the current science and is staying in touch with colleagues around the country and knows best practices, then most of that stuff should be coming from the physician with always welcomed input from the field. But my hope would be that the physician would be more deeply versed in the science behind some new medication or new procedure, or new device, et cetera, and be able to have a really great conversation with a field provider about the pros and cons and all the issues associated with bringing something new online or changing the direction of the service.
Thank you both for that, because I think that pretty much sums up at least what I think. But let's go into some of the bullets that ASEP has in their position statement. And I think this one, to me, is kind of one of the biggest impacts, because it really says that the medical director has a impetus to know everything that is going on. So this is the fourth bullet point on the first page. It says EMS Physician Medical Director should actively direct and oversee the operations of the EMS systems, communications, establish modifying dispatch training protocols, credentialing programs that serve in determining initial and ongoing dispatch privileges for communication specialists. So this is something that's interesting to me, and we've actually talked about with 911 dispatchers here not too long ago. Most of the time, we think of medical directors only touching what is going on in that ambulance, and that's not necessarily true. So what is your role, Dr. Heffern, in that dispatching or that pre-arrival information?
And I think it's one of those, that's kind of a role that, you don't really typically think of with medical directors. But I mean, that's what a lot of our, are those of us that are, really active in trying to improve our EMS systems. I mean, it starts with dispatch. We are actually in the past 2 to 3 weeks gone through all of our dispatch criteria. We've had internal discussions and that I've been involved in regarding the reorganization of actually our dispatch priorities. And then we're getting into multiple layers as well. We're, one of the pilot programs for ET3. So we're, actively looking to, get a nurse navigation line, which will then take it even further. But no, it's, there a a lot, especially, you know, from the smaller counties I'm involved in, really have a lot more kind of concrete, or, you know, generally where their, you know, EMD program and their EMD and the dispatchers themselves, it's much more restricted. You know, it's much more set. They buy, you know, they purchase you know, a specific program, and so you don't have as much hands-on. But when, you know, when we're starting to get into a, you know, a bigger EMS system, there's a lot more moving parts that you can get involved with. And
excellent points there, because, you know, what we do in the back of the ambulance a lot of times is based on what we get dispatched as. We prepare, we think, we look at protocols, whatever we need. And if we have to pivot because something in that pre-arrival information is wrong. So it's good to hear that engagement there. Dr. Holley, let's take a look from another one of your roles that you have. So you kind of serve, or you don't kind of serve, you are the chairman of the Clinical Issues Committee, which basically puts together what EMS providers in the state of Tennessee can do, right?
Yeah, the system in Tennessee is, you know, consists of the state EMS board that has directional and strategic level responsibilities, as well as sort of judge and jury for complaints and issues against providers, but also has several committees that are focused on education, air ambulance, and clinical issues, as you mentioned. And that one is primarily populated with providers, physicians, medics, EMTs, all across the board, and really looks and focuses primarily on the clinical practice of emergency medicine in the field. So we deal with the concepts of you know, new drugs, new products, new pilot programs that people are interested in doing. For example, administration of whole blood on ground ambulances in the field, and you know, kind of oversees the evolution of some of those things. We have a lot of discussions around scope of practice and best use of resources, educational needs, kind of all the factors that play into what really makes the real practice of emergency medical services in the pre-hospital world what it is today.
So one of the other bullet points in the ASEP policy statement is that you all, as the physician medical director, should actively guide and direct EMS system design that is based on evidence-supported clinical practices and outcomes. So taking a look from that clinical issues and even down to the service level with you, Dr. Heffern, you know, I, as paramedic David, come up to you guys and say, hey, I'm really interested in this. What are you all looking for? And really what I'm trying to get to with this is that engagement from not the service director level, but the field provider. So the paramedics, advanced EMTs, and the EMTs, they've been doing research and taking a look, and they see something that they believe is working. You know, another state, we'll say Kentucky, is doing a pilot. Or when I come to you as a medical director, or Dr. Holley, when we're bringing something to you at the state, what do you look for? And do you welcome that from that individual provider, not the service level?
Well, personally, I mean, I pretty much beg providers, you know, for that sort of input, because I mean, I'm a singular person. There is no way that I can stay up to date on, you know, every little nuanced thing out there, from the clinical side, from the operations side, either way. You know, so, you know, I've actually set up several different advisory groups, you know, especially within Knox County, you know, to provide that sort of feedback. You know, what sort of equipment do we need to be looking at? What sort of changes do we need to make to protocols, drugs, et cetera? You know, so, you know, one side of that is, you know, and then obviously, I mean, from the, you know, emergency medicine side, you know, staying up to date as an ER physician and kind of, you know, seeing your standards of care from that regard. But, you know, when something is brought in, or if I'm, you know, if I have an idea, if my brain is, you know, actually working that day, you know, I mean, the first thing you're going to do is, you know, you're going to look for your, you know, standards of care, so to speak. And unfortunately in EMS, there's not a great amount of those at, you know, NAEMSP and ASEP, you know, amongst others. There are organizations out there that have position statements. We from the state chapter, have worked collectively to develop some best practice documents to help guide other agencies with that. So kind of looking at those resources, and if that's not there, then you kind of have to take that next step out and do a deeper dive into research. Generally, I try and ask, any provider that brings me something to at least give me some reference point of, somebody else who's using it, and I can reach out to their directors, at least look at their protocols to kind of get an idea of how that's being used, and then, go out and do a literature search and try and figure out if that would be appropriate. Or reaching, also phoning a friend works, and giving Joe a call and seeing what he has to say on it, because he's probably thought about that and had some bigger discussions than I've had. And that's, that's really what trying to create, a network of, all EMS leadership, EMS providers, EMS physicians, at local levels, at state levels, at national levels, is to have that sort of communication. Because, if COVID did anything, it showed us that, when a wrench is thrown in, in the system, that sometimes, and we don't have evidence, a lot of evidence-based data out there, it can be really hard to make a decision sometimes. So having that communication is absolutely paramount in situations like that.
Yeah, and right before Bradley gets on, because I think he has a question for you real quick, but you were talking about the data portion. Have y'all gotten any blowback or anything, like you were really strongly feel a certain way towards maybe a drug or something, but you have agencies or other medical directors who are like, there's not enough evidence? Because I know by and large pre-hospital isn't studied with near the same depth that obviously the clinical setting is. Have y'all, like we just did TIMSA with you, so we got to hear all about ketamine and, all that. So, and I heard grumbles, because you're going to hear grumbles, and I just didn't know if y'all met that resistance.
And, speaking for myself, absolutely. I'm a champion for ketamine. And honestly, I've probably pushed it and rolled it out before we had a good amount of literature on it, especially up-to-date literature, because, a lot of these things, are, there's not a whole lot of new fancy things that we use. We use old tried and true medications. And so, rolling something out that, it basically was, used for years and years and years, and then, went by the wayside, and you bring it back. And you can see it, you're getting a large amount of literature coming out now, on something like ketamine. We would love to make a decision, with absolute certainty, with, multiple randomized controlled trials. But at the end of the day, it's hard to find that degree of evidence on a lot of things anymore.
All right, so I want to jump in real quick with something. Obviously, we have two very involved physicians here, and I'm going to make a bold statement for all of the EMS administrators out there, as well as the other paramedics that are listed. If you do not have a medical director that is involved from dispatch to disposition, as well as continuous quality improvement, discharge them of their duties and find somebody who will be involved.
Yep. I don't think I couldn't say it any better. Let's get a quote for that. We're going to put it on our website.
We'll get that little snippet and make that happen.
Exactly.
We got to work with that new social media manager for you.
There you go,
Dr. Heffern.
Yeah. So I'm very fortunate. We have two medical directors locally. I talk to each one of them, a couple times a week. Our state medical director once or twice a month. Very involved, great individuals. But medical directors should be the medical conscience of the EMS agency and have their pulse on the care that is delivered to all of the people under their purview.
Beautifully said.
Yeah, no, I got nothing. You summed up these position statements beautifully. It's and I think that you're starting to see. I think a lot of the issue in the past, and Joe, you can probably piggyback well better than I can, is that of the availability, because EMS doesn't pay, what any of us can make, being just an ER physician. And so it really has to be a labor of love. I know it's a passion for Joe. It is definitely a passion for myself. But it takes a lot of time and a lot of work. And, you've got to find those people who are interested. And unfortunately, they've been few and far between. I think you're seeing a change in that culture, within emergency medicine. EMS is our largest fellowship by far now. And it's literally been around, as something you can become board certified since 2013. I think there's a little less than 900 of us that are board certified now across the United States. So, you don't have a whole lot of people out there, but it's growing. And I think, as we develop EMS, work with, the people who've built EMS to develop EMS as a true medical subspecialty, you're going to get more and more input on that. And you're going to have the availability of people wanting to get out there and do exactly what you said.
Yeah. Well, and the other thing is if you're an EMS administrator or work in EMS, make sure that you are paying your medical director appropriately is another big thing I would say. At least cover their malpractice insurance, but you've got to give them something for what you're asking from them.
So how much do we owe you after this?
You don't owe me anything.
Well, I think we have a couple of clips. I think the second part is the commercial that we're now getting ready to shoot for Dr. Heffern there. So let's expand that engagement component, because one of the key areas that we've hit here, actually multiple times on the podcast as well as being in the position statement, is the need for the medical director to direct and oversee the continuous quality improvement program. So what does CQI look like for Dr. Heffern?
If there's one thing that's tough to build in a system, it's a good quality improvement process. We are very good about reviewing charts one-on-one, and especially providing that negative feedback. It is something I'm really still trying to build within my systems, because I'm literally learning how to do it as well. We're all taught how to train, to give presentations, to do hands-on training. We're trained on the medicine and, writing protocols and all that. But quality improvement is something that is not taught, very well. It goes beyond research and it really gets, uncomfortable at times, but it's probably honestly the most important thing we do, because it's how we know if what we're doing works, to be honest with you. And it drives our training, it drives our processes, everything down the line.
And I'm wondering about that. Like, if we're not getting, as a medic, as brand new or seasoned, it doesn't matter. If you're not getting routine or some type of feedback more than just the negative feedback when you do something bad, have you seen instances where like it makes the medics worse, or is there an increase for liability on that end? Because I just remember I didn't hear much because my reports are usually really well written. They're really good. I didn't really have many times where I would get slapped on the wrist or even had anything. And it's kind of bad because I'd never got much feedback, even positive feedback. Mostly it was like good report. But I'm like, but wait, was it good medicine? Like, did I do the right drug? Did I do the right dose? Was this the correct decision? All I had was good report. So I guess it went through billing. So I know that it probably got billed properly.
Well, and this is actually one area that I actually specifically asked about when I was still in the field before coming to the academic side. I was within my first couple of months of being a paramedic. And my question to the EMS office at that point in time, at least one of the individuals in the EMS office, was I would like to know what the outcomes of my patients are. And because, we make a decision in the field and we could be right or wrong. And the only time we really ever know if we were really wrong is when we get hit with a subpoena and somebody is starting to come up with a lawsuit, or at least, there's probably some communications beforehand. Hey, there are people interested, they're getting reports and stuff like that. But really, with that, what is there? So I pose this question to Dr. Holley, how, taking what Dr. Heffern said and looking at your experience, how can some of these, especially new EMS medical directors, look to, as ASEP says, actively direct and oversee their CQI process so it critically appraises and advances the quality of clinical performance?
Well, I think a lot of that has to do with just being involved and knowing what's going on. And by that, I mean everything from deciding to pull up chart number 5, in your EPCR today and take a look at it and see if the guys did a good job, did they follow best practices, et cetera, to every time a complaint happens to come in, you go and pull that chart and you take a look at it. And in many cases, I think particularly historically, that's always been seen as a negative. It's a gotcha moment, right? I'm trying to find your mistake so I can punish you for it. I tend not to take that approach unless it's pretty obvious that the provider is really not interested in doing a good job. And the vast majority are. And so it's an opportunity to say, hey, did you know that lady that you responded to yesterday, today showed up in the ED with XYZ? And I look back on your chart and her complaint was not exactly related to that, but there were a couple of things that she said that were a little concerning. Be sure to think about XYZ next time you hear those kind of complaints so that we can do a better job of ensuring that that lady doesn't get overlooked and either directed to the wrong level of care or not transported or whatever the case may be. So I think it's staying focused on looking to educate people about the best ways to do things, to have some prolonged conversations about what the current state of the science is. And I think that also relates to requests from the field to add a new procedure or new drug, as Todd was talking about a few minutes ago. We can spend the next hour talking about RSI and what a fantastic tool that is and what an incredibly dangerous tool that is. And it is both of those things. And it's all about not what you do, but how you do it. And explaining that to someone who's really pushing to say, man, we just really need RSI because in the last year I've had one patient that really needed RSI. And, so therefore I got to have it for everybody and sort of talking through, okay, I appreciate there's one, but understand what it takes to do that. Understand the QI process behind that, the training behind that, the risk behind that. And, in the big picture, do we have other options that are less risky and might still accomplish the same thing? So it's just sort of hearing out the ideas, giving them credibility and talking through them, whether you come to a conclusion or not.
Hey, so, this is kind of along that same string since we're talking about CQI and stuff. And since we have two medical directors here, I think it's a great time to ask this question. What are the top errors or the top things that you see that medics consistently make, or that you've seen that you're just like, I don't know why we keep seeing this over and over. These are patterns that keep repeating themselves because I think about our following that we have on Facebook, and a lot of them are brand new people coming in EMS, but a lot of them are service industry. And I think there's a lot of misconceptions as to what we get wrong in the field, but y'all have a unique insight. So I figured I'd toss that out there.
Well, I think that's a great question, Eric. I'll jump in on this because I literally just finished reviewing a case a few hours ago. And for me, I think an important approach for anybody in the field is, as you are getting a history from the patient and examining the patient and obtaining vital signs, et cetera, if you find something that is abnormal, address it in your documentation. And so it may be, I noticed this guy's pulse rate is 96. Oh, hey, it's he just finished running a marathon, and Okay. What do I need to do about it? Nothing. Okay. But I recognize that it's abnormal. And as I look back over legal cases, particularly by that, I mean cases that have been filed that involve EMS providers, they'll make mention of, this guy called EMS because he had this terrible headache and said his legs wouldn't work. And they get on scene and the complaint is, bad headache, my legs were numb, and there's zero neurological involvement or zero neurological assessment of even whether or not the guy can walk. I'm like, wouldn't you think that would be an important question if the guy says his legs don't work and all you do is note that, put him on a stretcher, note his vital signs are normal, and take him to the ED? What? So pay attention to things that are abnormal and note them. I'm not saying intervene on all of them. I'm saying many of them may be expected abnormalities and I don't need to do anything about it, but I at least recognize that that's not normal. And if the patient complains that, my little finger is blue, for crying out loud, look at their little finger and document whether or not it's blue and the capillary refill is okay.
When you have a patient that says, I have no fingers, I can't feel my fingers, find out if they're still there or not. Because in that case, he didn't anymore. That was his complaint. So, Dr. Heffern, you were going to say?
Just piggybacking on that, there's not a whole lot of major egregious errors. I think the majority of what I've seen within the QA process is the failure to document. There's poor documentation, especially medics, and trust me, if we start running docs in the field, it'll get even worse, frankly. But I don't think that the general, especially the newer field crew, really understands how important that documentation is, and the electronic PCRs that we're practically all using now. They're somewhat of a curse because it's very easy to just go through. Here's all your check boxes. The biggest deficit that I see is really painting that picture. So Joe mentioned it of if you see something, making sure that you do something about it and document that. And it's really if you need to paint a picture of what's going on. And then, the biggest thing I try and impart on my crews is really, you need to paint a picture of your decision making, because I can read through your chart and know exactly what you did. You didn't do a glucose. If it's not in the chart, it never happened. But seeing your thought process of here's this patient and why I did something, or more importantly, why I didn't do something or did something that may have gone against protocols, is really omitted on many, many, many charts.
I think Todd makes a really good point there. And that is, if I can't understand your decision making, I can't support you. And what I want to see is, I understood there was a problem. I chose not to give this nitroglycerin to this chest pain patient because their pressure was 100, but they weren't perfusing very well. And I know the protocol says less than 90, I shouldn't give it, but I thought 100, and the guy not perfusing well was still a good reason not to give it. Hey, I'm behind that 100%. That was the right decision to make. But I can't support that unless you explain to me why you didn't, quote unquote, follow the protocol, because the attorney sure thinks you should have followed the protocol. And it's actually part of the reason that I have a protocol for not following the protocol. I need to know why you chose not to do that. And if you can convince me that, a 45 round to the head is the right treatment and it's medically sound, I'll support it. Obviously, that one's going to be a bit of a challenge to be medically sound on, but I got a couple of patients that will qualify for. So, it's just me needing to understand your decision-making and knowing that your decision-making is based on reasonable, sound medical principles. And I can support you for almost anything that you do in the field.
And here's the reason why I bring that up. I don't want medics, and I'm going to make the statement. There's a lot of medics, and I've heard this before, is like, well, the reason why I'm a paramedic is I don't have to do what the doctors tell me. And my whole thing is, yes, you absolutely do. In fact, you should love protocols. There used to be this culture of you're not allowed to touch the protocol book. You should have it memorized, or you're just a bad medic. It's got dust sitting in the corner. And I just want to reemphasize that should not be the case. Heck, if you can make them into little note cards that you can put weather taping or something on so that you can reference them at 2:00 in the morning, you absolutely should. The culture of ignoring protocols is to your own detriment. Those are there for a reason. I'm saying that as somebody who followed it line by line. And if I went outside of it, it has to be documented, because there's another culture that we're also fighting against, which is minimalist documentation. Just document the bare minimum. Don't worry about if you put too much information, they'll just trap you. But if you don't put enough information, you're not going to be able to paint the picture, which I've never heard it put like that. Paint the picture of your decision-making, not necessarily of the entire scene, but of your decision-making process. And it has to do with protocol. So I just feel like it's dangerous to have cowboy medics who are functioning like renegade physicians who are making medical decisions regardless, because they may not have an active medical director. That's what I'm afraid of. And I don't want to impose that that's the nature of our job, because it's not. We are not physicians. We are nowhere near it. And I don't want anything to be near it. And there's a reason why they're there. They're to protect us, and it's ultimately to protect the patient.
Yeah, I think there's a an art to that, though. That, and again, David has a great question on when we're doing the interviews for the paramedic candidates. What's the difference between a technician and a clinician? How do you see yourself within that? And but it does come down to that and that's what within EMS we've got to take that paramedic and elevate them to that point where they're more comfortable, making those clinical decisions. And then we, from the medical director side, are more comfortable giving them a more open toolbox to make those decisions.
So I do want to point out real quick that Dr. Holley has not authorized the 45 round to the head at this point in time.
I have not.
And so just putting that out there.
Stay tuned.
That is not a state change.
He didn't say no.
That protocol is not published. I'm just saying.
Clinical issues is Wednesday.
That's it. We'll be talking about it.
It may be a draft format, but it is not approved. Just putting that out there. And I've always kind of used the example when talking to students about painting the picture. You've got to paint the picture. It just doesn't have to be the 3D image. Like, you don't have to go in with all the extraneous details, but you do have to discuss and talk about that. So let's talk about that in the realm of developing training. So right now in the state of Tennessee, I can take CPR, ACLS, PALS, PHTLS, and probably one other course and just about satisfy my requirements for continuing education as a paramedic. I know my feelings, but I'm going to toss this to the docs. Is that the way to go?
That's how you can make money on it. No, no. And again, we've had these fights internally. There's a bare minimum, and I mean, I know Joe shares the philosophy that we need to have a floor and build from that floor as far as our training and our expectations. We too long EMS has worked under this philosophy of, well, that's the ceiling. That's all we can do. Those sort of trainings, and we can make arguments, are they necessary in their length and their cost and all that. But at the end of the day, I mean, this is closing the loop of that QI process. You're evaluating your system. Training is the way to both communicate with our crews, what we're looking at, what we're seeing, and set our expectations. And if we don't have that, then there's no way to improve an EMS system and we frankly have a functioning EMS system.
So this really kind of goes back to what you were saying, that active role of the medical director. You have to be taking a look, going through that CQI process, taking a look at what you're seeing as far as trends. And this, other than the documentation, and this is where obviously documentation plays a role, but kind of seeing that, hey, we're seeing this uptick in X, diagnoses, and we need to look because this stuff is not being used, or that's not being used, or we're not getting the outcomes that we might be getting if we would be doing stuff maybe a little bit differently, right? So in most instances, most of our medical directors are part-time. They are contracted with the services. They're not there consistently. And so getting in this active role, and then we transition to this, because most of those medical directors aren't in the classrooms. They transition that over to the training officer. How do we get that kind of buy-in? Because again, those out of the box thing, or the inside the box things of heart association, CPR, BLS, ACLS, or PALS, ACLS, those are already packaged. We put it in a DVD. There's a test. So we have the content, we have the assessment. How do you get the engagement from within the services to say, hey, we can take a look at those, but no, we really don't need to put all of our eggs in that basket?
Well, a lot of it has to be funded. And again, it's very similar to the QI process, is that the services have to understand it. Again, this is a, communication issue, from the administrative side of sitting down and, identifying the, deficiencies in the system, not just from the QI perspective, but, and how we can address those from the training perspective. And the training has, it has to be a very, high quality. It's got to be something that you're engaging the crews with, that's pertinent, and that you're going to be able to, again, continue that loop closure and to show that it is beneficial and that you're improving that system. But a lot of it unfortunately has come down to funding, because, we've mandated all these classes, and, sometimes it's very difficult depending on size of agencies, especially your non-fire based agencies, obviously, to get that financial buy-in sometimes.
So I got to jump in on this. While I think those courses that you mentioned have great value, there is solid information in there, and there's certainly value in a core base of information related to that. I think that is lazy training. Mm-hmm. They don't change much. I would bet that the PHTLS class that you take now is the same one you took 10 years ago, yet a lot has changed. And it is not ever going to be the training that takes your service from okay to great. Mm-hmm. And I think, as Todd has mentioned, if you want to do that, your training needs to be focused on the needs of your people, the responses of your service and your service area, and to a great extent, the expectations of those that lead and pay for the service. So I think one thing that we have not done well in EMS is we have not done a good job in educating mayors, city councils, whoever it is that is responsible for the administrative and financial oversight of an EMS service. And therefore, we have extremely dated and pretty unproductive benchmarks for performance. We expect 90% of our calls to be there in 4 minutes. Why? Why should we do that? How many people are we going to kill to do that so that we can get to the stub toe in 4 minutes? There's a much smarter way to do this. It takes a little bit of tweaking and tuning, but it's definitely doable. And so why wouldn't I want my city councilman to say to me, I want to see a 20% improvement in our cardiac arrest survival rates? That's what I expect you to do. That's how you make a great service. You drive it toward patient outcomes, not administrative outcomes. But those are easy, and anybody can look at the numbers and go, oh, I'm disappointed that my ambulance didn't get here in 6 minutes. But I think it's part of what we have to do to change the QI, quote unquote, expectations of what we do in EMS.
Well, as our time is starting to wrap up, there's one important point because there's a lot of individuals out there that think all of these discussions are being had between those medical directors, the service directors, those medical directors, the Department of Health, the medical directors and the board, city, county, state officials, et cetera, and they're not there. So Dr. Heffern, if an individual wanted to get involved with the medical direction side, are they able to do that, and how would they go about it?
Well, I mean, you're talking about from a physician becoming an EMS medical director?
No. For our ground crews that are wanting to get involved, more active in the medical direction side, so working with you all, those kind of things, how would they go about that?
Well, I mean, a lot of it is I mean, I have a very much an open door policy, David, as you're aware. I mean, I would venture to guess that a good portion, if not the vast majority of the at least the paramedics, have my cell phone, email. Again, I'm get out there, talk with them, do the teaching like we've done over the past few weeks. But I think there needs to be an informal layer, and there needs to be a formal layer as well. And so, we've got some different advisory groups to to try and encourage people to get more involved. And I think from the bigger picture of EMS, as we continue to grow, we need to have, more buy-in. We need to have more ability to to get promoted, and having things like advisory groups and FTO positions, and kind of sub-supervisory level administrative things as far as like with QI and training and everything. Those are the things that the fire service has done a very good job of, and we have not done that in EMS. So I think there's an administrative side of that, and then there's just the personal side from the medical director of setting up mechanisms for individual communication, and then also kind of more platforms and discussions, both internally in an agency or, bigger picture as far as in a county or in a region, or, from Joe's perspective at the state level. And, from us, and that's one of the things that we've tried to, really emphasize with our chapter of the NAEMSP is, we're not just physicians. We're here for leadership. We're here for ground level crews. We're here to be a platform to listen to you all, and to, to communicate and help coordinate that, at all these different levels.
I'm going to toss in there one plug as well, because I've actually seen it myself. The National Association of EMS Physicians is actually highly encouraging. That's not really a great way to put that. They are very encouraging to having EMS providers actually join their organization. In fact, they have a scholarship that is designed to send multiple EMS providers to their organization, as well as pay for their membership into the chapter or into the organization, as well as their state chapter, so they can be involved. And through that involvement, you start to shape decisions. You get involved with research, and those are some of the things with the Tennessee chapter. Let's change that though to Dr. Holley's side. Dr. Holley, a lot of times people look at the EMS board and they see kind of their disciplinary action side, because they're the ones that do the adjudication on all the EMS licenses there. And so whenever you watch a board meeting, they're going through cases, but they're not only there for that. They're actually open to discussion and conversation and points that come across. So if somebody wanted to get involved at the state level, what is some of the things that you recommend as far as coming and or simply just talking to these individuals?
Well, so that's a great point. That the adjudication of complaints, et cetera, at the state board level is incredibly time consuming. And has its aspect of, drama and fascination to it. But an awful lot more goes on behind the scenes. I think a lot of this, as Todd said, is really just engagement. That is an open meeting. People are always welcome to come. The board is a very relaxed and open group of folks that love EMS and like nothing better than chatting with people. I think it's reaching out to be involved in your own service. Todd and I are always looking for champions in the field, right? That understand the things we're trying to get done and the importance of them, and to help carry that message forward. I promise you, if you call up your EMS medical director or the medical director's office or the QI office and say, man, I'd really like to get involved in some stuff over there, it'll take about 3 seconds for you to be invited in to help out. So, we would love to have more folks just appreciate what goes on there and the reasons that it's being done, and to appreciate that it is for the betterment of the specialty for all of us, and most importantly for our patients. So I think it's just make the call, show up, and just say, hey, I'd like to help. I'd like to do some more here. What can you have me do? I promise there's plenty of things to do.
Very, amen. Got the testimony there. So normally, as we get done with the episode, we give you an opportunity to just kind of wrap up what we've discussed. But we've had so many topics here today. I'm going to pose one last question to both of you. I'm going to start with Dr. Heffern first. Where do you see EMS medical direction in 5 years? And you can take the profession as a whole and how you all fit in, or just the medical director himself. Where do you see us in 5 years?
I think 5 is, maybe a little, short-sighted as far as seeing dramatic change. I mean, I think, 10 to 15 years is probably a little more realistic, honestly. But, the hope is we continue building this foundation. You can't just go out there and, write a policy. And trust me, Joe and I have talked about this, and, a lot of us have across the state of, well, let's just mandate that, every service has to have a board certified, it's never going to happen. And so, a lot of it is that engagement, at each level, local, the local agencies with their ER docs and reaching out to them. But, I think you're going to see more and more physicians getting opportunities to be more proactive. I think across the board, you're going to hopefully see, and I would love to see this in 5 years, but to really have the agencies, getting, more on board with the, these non-letter classes training, with the QI processes, and there's a financial, side of that as well of you've got to get these things paid for, unfortunately. But I think in 5 years, you've seen a fairly dramatic change even in these past 5 years as far as the level of engagement, the level of interest, and hopefully we can kind of just continue a nice logarithmic rise. Again, my expectation is probably more in the 10 to 15 year range, as far as for dramatic change. But I think, in 5 years, you're going to see a substantially, larger proportion of agencies with active medical directors and a lot more younger EMS physicians out there.
Dr. Holley, how about you?
Yeah, so I'll take two perspectives on this. I think from the standpoint of EMS in general, we will see dramatic changes over the next decade as we look at new scopes of practice, new models, new ways of paying for what we do, as opposed to paying to transport people around, and that's going to change a lot. I think from an EMS medical director perspective, there is tremendous interest and excitement with current young physicians and EMS. I sense a lot of excitement about a place for them to really make a difference. Emergency medicine in its sort of traditional form, particularly related to the current pandemic, has gotten to be a very challenging practice. It's very hard to be an emergency physician now and to work clinically, but to be able to take some of that frustration with the system, that knowledge and that drive and carry it out into the pre-hospital world and try to change the way the system works is incredibly exciting and will be incredibly impactful over the next 5 to 15 years.
Excellent. Eric, what's your parting shots for the day?
My parting shots would be I like speaking to the new people in EMS, like get to know your medical director, email them if anything else, just to introduce yourself, and maybe even if it's in some of these small towns, might be able to go get a coffee with them or just sit down and talk to them at the station one day. And just kind of, because I think you can get a different perspective of EMS if you talk to one of the medical directors than if you kind of just stay. I wish I would have done it. That's basically what I'm saying. I wish whenever I got in, I would have been a little bit more proactive with my own medical director. Now that I get to see EMS physicians who are actually fellows in EMS, it's really cool talking to them and stuff. Heck, they get to ride in the ambulance now. Many of them have to spend like an entire month, so they get to see what we see, and they go, "This kind of sucks." Sometimes I'm like, "Yeah, it does." So they get to hear from you, and you get to hear from them. So I think it's good all the way around.
And Bradley.
So a couple of things I will echo is one of the things I said earlier about making sure you have an involved medical director. The other part of that is you, the EMS provider, and EMS admin have to be involved as well. If you do not engage your medical director, you're just as much at fault.
Excellent point. So tonight we've been going over a lot of the position statement that is put out by the American College of Emergency Physicians. So we'll definitely link to that as well, so you kind of get an idea. Dr. Holley, Dr. Heffern, thank you for taking the opportunity. My shot for 10 years down the road, even though she's wanting to be a trauma surgeon, we'll have to see how that goes. Maybe 10 years from now, we revisit this episode. We toss my daughter on there. Sorry, proud of dad this weekend. I think we all take that, and I'm sitting right here, so I have the opportunity to do that. So, but Dr. Holley, Dr. Heffern, thank you, especially at the last moment, jumping on and having this conversation about medical directors. I think there's a lot that people can unpack and take back, from the individual provider to the service director to also the medical directors that are out there. We want to thank each one of you for coming on tonight. For those that are listening, don't forget to go by our website, recently redone from Eric at emshandoff.com, and also our most active place in social media spaces, our Facebook group. So if you haven't yet, make sure to go by there, and also go by YouTube and subscribe so you get all of our episodes right at the very beginning. We always like to premiere those episodes Wednesday at noon, so you'll get those very first thing. But for my co-host, Eric McCullough and Bradley Dean, this is David. We want to say take care, stay safe, and always remember the value of your EMS handoff.